All right. Well, this morning we have a really exciting panel, and I will just introduce the panel members very briefly. You have bio sketches for everybody who will be speaking today in the program book, so we won't go through lengthy biographies. So I want to begin by introducing Dr. Sidney, who is from Kaiser Permanente, I think well known to everybody in this audience and tuning in via live stream, the author of the Sidney Report, among other things. And then starting from the end, from the left end, Betsy McKay, senior writer with the Wall Street Journal, Connie Hwang, chief medical officer of the Association of Community Health Plans. At this end, Dr. David Goff, Director of Cardiovascular Sciences for the National Heart, Lung, and Blood Institute at NIH. And in the center, Mark McEwen, journalist, author, advocate, and stroke survivor, and member of the National Forum Board of Directors. Mark?
Well, thank you. And David took my line, which was, go Nats. You have to say that. Tonight is going to be wonderful. So, well, you have to see the game. It's the 7th game of the World Series. That's pretty cool. My name, as John said, is Mark McEwen. What he said earlier about privilege. My stroke, when you have one, you want the world to stop because you have. It doesn't work that way. And the privilege of things like dressing yourself, shaving, driving, things you take for granted, now you have to relearn. So had to do all that. But it is a privilege to be here. And sitting to my left, it's a privilege to be on the same stage as him. Dr. Sidney wrote our signature report known as the Sidney Report. And Doctor, you're on.
Thank you, Mark, and thanks to the National Forum for inviting me here. I want to start by thanking my collaborators on the report that you have, the editors, Dr. Darwin Labarth, these people are all here, John Clymer, Julie Harville, and Laura Gordon. So appreciate that. And I also want to talk about, as you know, there's an accompanying article that you have that was just published today in JAMA Cardiology, somewhat broader than the Silver Tsunami paper. And I want to acknowledge all my authors, too, who helped out. They were all Kaiser Permanente researchers and or clinicians, some of them both. And particularly my senior author, Dr. Jamal Rana, who's the chief of cardiology at the Kaiser Permanente Oakland Medical Center, and really provided me with the clinical perspective on heart failure and the other heart diseases we spoke about, since I'm an MD, but I'm just a numbers person. I don't take care of people. With that, and one other thing, I also like to thank Betsy McKay on the end here for an absolutely beautiful article in the Wall Street Journal this morning, and you should all look at it. I think, Betsy, you said it'd be out in print tomorrow. Is that right? But it is online now. Yeah. So I'd like to start, I want to show you 7 slides and talk about them, and I want you to have an understanding of what's really going on and why things are different now. This cover is the cover of your report, and I like it because it's powerful and evocative, and it evokes really, I think, the dangerous and somewhat scary time we are right now with heart disease and with heart failure. If I could have the next slide. So this shows the number of deaths from heart disease going all the way back to 1910. 1910 is the first year in which heart disease was the leading cause of death in the United States, and it has been the leading cause in every single year after that, with the exception of the years 1918 to 1920, the time of the worldwide flu pandemic. And it's an interesting picture, and you can see it goes, up and up and up until kind of around the late 60s, and has a peak in the early 70s, comes down a little bit, and then it hits its all-time high in 1985 of about 771,000 deaths. Then after that, after 1985, it pretty much comes down at a pretty good clip until 2011. And that's the dip you see in the curve, and ever since 2011, it's been coming up. 2011 is also notable because we published a couple of years ago that the long-term decline in the rate of cardiovascular mortality, heart disease mortality, had just slowed to a very low rate. If I could again have the next slide, please. So this slide shows in blue, it's a shorter period of time, it's 2000 to 2017, but the blue curve is the number of deaths, and you can see that dip around 2011, and then it comes back up. And the red line is the rate of heart disease, and we can see it's continual decline, somewhat flattening out, and basically in the last 6 years has come down by 5%. So first question here is what's going on? So the rate's coming down, the number of deaths are going up. They're going up, actually, it was about 8.5% during this time period. And I want to make sure everybody understands the relationship between rate and population and number of deaths. So the rate of a disease or the rate of mortality is the number of deaths over the size of the population for a time period. So if you have 100 people and 2 of them die from whatever, let's say heart disease, over a year, then your mortality rate is 2 over 100, 2 per 100 years. Now, where population comes in is to get the total number of deaths, you multiply the rate by the population. In this case, if the rate is 2 per 100 and your population is 200 people, then the number of deaths is 400. It's 2 times that. It's 200 times the rate. If you had 1,000 people, then you would expect 20 deaths for the same reason. So this brings up the question, well, the next thing to look at here to try to figure out this puzzle is what the population's doing. How fast is the population growing? Because it is growing, we know that. And if you go on to the next slide, please. So this is the total population growth in the U.S. from 1999 to 2017. 2017 is the last year for which we have mortality data, and it's broken into 6-year time periods. The yellow bar on the left is 1999 to 2005, the middle blue bar 2005 to 2011, and the right-hand red bar is the most recent 6 years, 2011 to 2017. These are the percentages of growth, and you see they started out about 6, and it's the last 6 years, 4.5%. So the first thing you think, well, 4.5% increase is about the same as the 5% decrease we saw in the mortality rate. So these should kind of cancel each other out, and we shouldn't see any change in the number of deaths. But we did see a change. We saw a significant change. So what's that about? And then you have to think about what do we know about heart disease mortality. And what we know, one of the things we know, is that it is mostly a problem of relatively older people. And 80% of all heart disease deaths occur in people who are 65 years and older. And I refer to that as relatively older because I'm 70 and I don't feel old. And I think we got a bunch of people in this room who can probably say the same thing. But anyhow, that's Medicare age, and, that's the way it is. So the next thing to do then is to, take a look at that age group and what's happening with the population there. And if I can get the next slide, please. So, and this really tells the story here. The left-hand side is those 6-year changes in people under the age of 65. The right-hand side is people who are 65 years and older. And you can see that from 1999 to 2005, the population growth was about the same in both, but then it started taking off. 13% the next year, 6 years, and 23% growth of the 65-year and older population during the last 6 years. And that's the answer to the question. The appropriate denominator for the rate is mostly the people who are older, and that rate increase is way the heck faster than the decrease in heart disease mortality rate. And so that's why we get an increase in the number of deaths. If I could then go to the next slide, please. So heart failure, which is what we're mostly talking about today, that's a different picture. Because if you look at this graph, if you look first at the rates, which is the red-hand line, the red line, that one went down from 2000 until about the same year, 2011, remarkably, and then started going up. And though it, and you can see it, went up quite a bit. It actually went up more than 20%, and that's a lot, and that's the rate. Now, the heart failure deaths, there's an even more extreme distribution than for heart disease overall. It's more than 90% of heart failure deaths occur in people who are 65 years and older. So the combination of the rapid increase in the mortality rate for heart failure with the population growth of the impacted group has led to what I think could be described as explosive growth in the number of deaths, 38% increase from about 58,000 to 60,000. Or to 80,000, excuse me, during that time period, and making it really, if you separated it from heart disease, it would be the 8th leading cause of death in the country, right after diabetes. Next slide, please. And this just summarizes what we've just talked about and shows on the left, and the purple is the change in mortality rate, the right bar is the change in the number of deaths, and you can see this relationship again. For heart disease, the rate goes down, but the number of deaths goes up for the reasons we've just discussed. And for heart failure, the rate goes up a lot, and the number of deaths goes up even more, again, for the reasons we've just discussed. And if that doesn't seem kind of like enough of a bummer, let's take a look at the next slide, which is my final slide. And this is looking at the heart failure deaths in those under the age of 65. A small segment of heart failure deaths, but the problem here, I think, is pretty evident, is the number has gone up quite a bit from about 4,400 in 2011 to 6,700 in 2017, and that's an over 50% increase. And so this I liken to be probably like the canary in the coal mine. It's a sign that we've got a problem, and doesn't look like it's going to get better any soon because the younger ages are feeding into it. So I'd like to close up by spending a few minutes making remarks about this. First thing is, why is this a big deal? I mean, isn't it? It's nice that people are getting older, isn't it? A lot of people are getting older. The population of relatively older people is increasing, and it's going to increase even more. And I have to mention that that's part of the concern here, because the 65-plus population is expected to increase by 2030 by an additional 44% to 73 million, and that's 22 million more than it is about now. So whatever's going on here is going to get compounded unless we, can make real progress in pushing the mortality rates down. So, but, you do have to die from something, right? and it's just inevitable, unfortunately or fortunately, depending on your viewpoint. And maybe heart disease, heart failure is not such a bad way to go. And so the answer to that is no, no, no. It's not a good way to go. There's a lot of disability with heart failure, dependence, disability. If your heart's not functioning in a manner that can support your normal activities, that's a huge problem. So I think the issue about getting older is we're not just celebrating the fact that people are getting older. What we'd like to celebrate is that people are getting older with a good quality of life. And heart failure and lots of heart disease do not offer that to you. So it's a big problem. We need to fight it. Now, there's an additional dimension is the cost to society and the economic costs. Heart failure is very expensive. People with heart failure have 4 times the hospitalization rate, the fee-for-service Medicare population, 4 times the rate of hospitalization of the rest of the Medicare fee-for-service population, 3 times the cost. So it's expensive. Total costs were estimated at about $30 billion for heart failure in 2012 and estimated to increase to $70 billion by 2030. So this is, it's not just a medical problem. There's a couple of problems here. One is that we've got a lot more patients. We've got to be able to provide the care for them. We've got to be able to pay for the care. And so this is the baggage that comes along with this seemingly nice increase in the older population, but the struggle for resources to deal with it properly. Finally, just wanted to say a couple of words about what to do about it. I think in the long run, the thing to do is prevention, prevention, prevention. We have, Heart Association has developed the Life Simple 7 lifestyle characteristics and physiological characteristics that protect you against heart disease. Fewer than 20% of the adult population have even 5 of these 7 heart healthy behaviors. So we need to be able to do much better than that. Changing behavior is difficult, getting people to do better diets and physical activity, but we have to work on that. And then on the other side, particularly with heart failure, there's a form of heart failure. There's 2 forms depending on how your left ventricle, the main pumping chamber, works. And it's so-called heart failure with preserved ejection fraction, where the pumping function is good, and heart failure with reduced ejection fraction, where it's bad. Now, we have a lot of good treatments for the bad ejection fraction, but we don't have any disease-modifying treatments at this point for heart failure with preserved ejection fraction, which forms an increasing body of the number of cases of heart failure. So, the message for the forum here, I think we're all, prevention people, and, this is a time to amp it up. I mean, we need to get the word out here. We've got just in the midst of an incredible problem, an incredible tsunami of the population of heart disease and heart failure. Thank you.
I have a question. I don't know if you know the answer to this one, but where does the U.S. stand in the world as far as heart failure deaths go?
I actually don't know. There may be somebody else in the room who does. I looked up, for that information, and there's, some information about heart disease, but I could not find it about heart failure. Maybe somebody else in the room, David or somebody else, has an answer to that.
Okay. Ms. McKay, you report on the heart failure tsunami that is taking you to patients who have it. How does the disease affect their lives?
Well, thank you. I have talked with some patients, and actually my own mother-in-law had heart failure and died with it. And, you know, in talking with people and in watching her, it's really, you know, to Steve's point, when you're old, you are going to die of something, but this is something you definitely do not want to be suffering from. It was incredible suffering, you know, anguish, and just this sense of the body shutting down with her. She, you know, I just kept having this image in my mind of someone drowning in their own body. That's kind of what it's like, because your heart just can't keep up, and you know, you can't circulate the fluids, and she was in and out of nursing homes and hospitals. At one point, she had to be she lived in a rural area in the later years of her life and had to be life flighted to a hospital. Her ankles were so swollen. So and it was horrible. I won't go on. I'm sure you've all seen it, but you know, it's horrible and expensive for the healthcare system. The other interesting thing I find in talking with people is that when they're diagnosed with heart failure, they're very surprised. You know, it comes on in this way, which is sort of you're more fatigued. You have trouble, all of a sudden you're out of breath, but it builds up over months. You think, you know, a woman I talked to, actually the woman in my story today, who's 56, said, you know, I just kind of thought I was out of shape, or whatever. She was caring for her husband who had cancer, and just not paying attention to her own health, as none of us would if we were in that situation. And you know, just kind of felt increasingly fatigued, but you don't notice it as it comes on day to day. Another issue people face once they're diagnosed, I think, is coming to the realization that this is something they're going to have to deal with for the rest of their lives. So every single person I've talked to with heart failure who is on medications, you know, some battery of medications for it, all says, I'm hoping, or I would have liked to get off these medications. You know, I'm only 56, or I'm only 63, or whatever. You know, but my medical team, my cardiologist, my doctors tell me I'm going to have to be on these medications for the rest of my life, and I've just got to get used to that. So, but there are some good stories. The woman in my story has changed. Today, turned her life around. And then I wanted to, my story posted online overnight, and so I'm getting emails, and I wanted to read just a snippet of one email I got this morning from a guy who said he was diagnosed with heart failure 20 years ago, scared the hell out of me. In all the time since diagnosis, I've been completely stable. That's because I'm scared, and scared makes me vigilant. He said he rises each morning at 5:15. He works a full week. He walks. You know, the only reason I know I have heart failure is because I'm at the doctor regularly. My father died of heart failure at age 87. I'm positive that had he been more vigilant with his health, he would have lived for another 5 years. I really appreciate your piece. I hope it makes people think. Death rates can go down if people just deal with what's in front of them. I do, because I fear an early death. So, you know, for some people it involves, if they can, taking their life, you know, turning their lives around. My mother-in-law was not at a point where she could do that. So I think everybody is affected in different ways. There was nothing she could do, and there was really no treatment for what she had. It was basically riding it out. So I've had a pretty broad series of opinions and experiences from talking with the people I've talked with.
Dr. Goff, can you please outline NIH's research agenda that could help us prevent heart failure and treat it more effective.
Well, thank you, Mark, and it's a real privilege to be here on this panel with these colleagues. Heart failure is a major public health problem, and so it's a really important part of our strategic vision implementation plan. It's one of 6 areas that we've identified as important for our strategic investments going forward. And as Dr. Sidney mentioned, there are really 2 important subtypes of heart failure, perhaps a few more, but we talk about 2 major forms. And it's important to understand that the heart is a muscle that pumps, and so for the pump to work, it's got to relax well and it's got to squeeze well. And it has to do that with every beat, relax well and squeeze well. And so the 2 types of heart failure are generally described as the type when the heart doesn't relax well and the type when the heart doesn't squeeze well. We have much better treatments for the type where the heart doesn't squeeze well. That's the heart failure with reduced ejection fraction that Dr. Sidney talked about. Even though we have some really good treatments there, there's still a lot of morbidity and a lot of mortality associated with that kind of heart failure. And that kind of heart failure tends to come from the type of heart disease that we've known about for a long time that leads to heart attacks and damage to the heart muscle, and the heart muscle doesn't squeeze well. This other form where the heart doesn't relax well, that's a type that's been really appreciated more over the past decade or 2, where it's become more commonly recognized as a cause for the kind of symptoms that Betsy McKay was talking about a little while ago, the fatigue, the breathlessness that occurs, especially in relatively older individuals. And we don't have very good treatments for the type of heart failure that comes with problems of the heart relaxing well. We've tried a lot of the treatments that work for the other kind of heart failure, and they don't tend to work for this kind of heart failure. So there's something different about the cause of the kind of heart failure that leads to the heart not relaxing well. So we need more research on the causes of this kind of heart failure. We need research on the basic mechanisms so that we can then develop models, whether they're animal models or whether they're kind of tissue models or cellular models about the underlying defect in the heart that keeps it from relaxing well, so that we can develop new treatments, drug treatments, to treat this kind of heart failure. This kind of heart failure is more common in women, relatively speaking, than the other form, which is more common in men. This type of heart failure is also more common in some underrepresented minorities, especially African Americans tend to have more of the heart failure where the heart has trouble relaxing. It also seems to be more common in people with diabetes or severe obesity, which might be pointing us in a direction of some of the causes and potentially some of the treatments for this kind of heart failure. So we need more research in those areas, but I couldn't agree more with Dr. Sidney that we also need more research on prevention. If we are better at preventing obesity and diabetes and high blood pressure, might we be better at preventing heart failure? Both types of heart failure, actually, the kind where the heart doesn't relax well and the kind when the heart doesn't squeeze well. So that's really where we're looking at present in our research agenda, trying to understand those basic mechanisms so that we can develop better models for drug testing and drug development so we can do more trials in humans, and really trying to raise the focus on prevention research.
Your turn.
Sounds good, Mark.
Dr. Hwang, tell us what health plans are doing today that is preventing heart failure, reducing the burden of preventing heart failure, and reducing the burden of heart failure.
Great. Thank you, Mark, and good morning, everybody. It is a pleasure to be on this panel. I would say probably the most important and impactful activities that members of our association, in terms of the health plans, are doing in response to heart failure is really partnering with physician groups in effective ways to accelerate that adoption of evidence-based practices in dealing with things like hypertension and diabetes. So maybe a little background about who we are as the Alliance of Community Health Plans to give you a little bit of framing about some of the perspectives of the work that these groups are doing in light of cardiovascular health and heart failure. So the Alliance of Community Health Plans is an association of nonprofit, regionally based community health plans who care for over 20 million Americans across 34 states and Washington, D.C. So our members are widely recognized as innovators in population health management, but also those who consistently perform at the highest quality levels. So just to give an example relevant to our conversation today, when you think about one of the major causes of heart failure for hypertension, we know, unfortunately, CDC has shown us that blood pressure control rates have dipped slightly below 50% across our nation. Our members of ACHP, when it comes to blood pressure control, typically perform somewhere in the 70 to upwards of 90 +% in terms of blood pressure control across multiple populations. So this is Medicare Advantage, commercial, Medicaid populations. And I think the sort of secret or the successful approach of our members really has to do with integrating care services. So the majority of our members are integrated care delivery systems. So this is where health plans, hospitals, and physician groups are actually all under one organized umbrella, one umbrella organization. We also have members who have long-standing ties in their communities and have really aligned with those physician groups there. So I think when you bring these two things, these two entities together, in ways that really produce effective partnerships. And I'll talk a little bit about some of the features of that maybe later in our conversation. But when you do that, I think you can really generate those types of clinical improvements that are sustainable and also, importantly, at scale.
This is a question for you and for Dr. Goff. Certain interventions have proven to reduce risk factors for cardiovascular disease and heart failure. So if they do, why aren't they being implemented?
So I'm happy to take a quick stab at that first. So I think, we don't lack for evidence on what we need to do. Right. I think this is a challenge of consistent implementation. And so one thing I'll mention, ACHP, about a year ago, we released a report sponsored by PCORI, the Patient-Centered Outcomes Research Institute, where we conducted a series of structured interviews and roundtable discussions on what really is needed to drive these clinical improvements in partnership with payers and providers. And so there are 5 things that have been identified, and sometimes these are hard to bring together all at once. And so, these include shared commitment to leadership, multidisciplinary teams, customized education and access to specialized resources, so that, in short, making the right thing to do is the easy thing to do. 4th thing is timely, accurate reports in a culture of transparency. And 5th is really financial incentives that are really aligned with the clinical outcome you want to drive. So these types of factors, I think, when you bring them together, you can really move the needle. But again, you can just, even in all of those, I think some of these things can be very challenging.
Okay, your turn.
Well, thank you. I think there's a combination of answers around policy, practice, and research. And as a representative of the National Institutes on Health and the National Heart, Lung, and Blood Institute, our primary responsibility is really to support the research on these issues. So I'll leave some of the discussion of some of the policy issues and practice issues that could really make a difference in control of risk factors to other members of the panel. From a research perspective, there are barriers to implementation of knowledge that are still not well understood, and we still don't have really good evidence-based interventions to implement in practice what we know works in research studies. So when you do a research study, it's typical that highly selected individuals who are motivated to participate in the study are recruited, and highly motivated practitioners who are interested in participating in the study participate at their clinical site. And the intervention is delivered following usually a very well spelled out algorithm or protocol and under really ideal conditions. And so the results of that research study are going to be about as good as it gets, right? So then if you try to translate that into the real world, as one might say, into real practice, you have a different set of patients, not just the ones who are highly motivated and volunteering to participate in a study. You've got a different set of practitioners, not just those who are highly motivated to participate in a study. And you've got a much different set of circumstances in which people are working in a highly interruptive environment with lots of different problems showing up on their doorsteps. And people aren't just there to take care of their risk factors for heart disease. They're there to take care of their health and their life. So to expect that we're going to see the same results in practice just because we have a successful research study is not realistic. So we need to do more research on how to take those interventions that have shown effectiveness in research and learn how to implement them in a way that comes as close as possible to that impact in practice. And we're not there yet. So we need more practice-relevant research. We need more practice-based research so that we get out of the places where it's easier to do research. I won't call it easy, but it's easier to do research in these highly controlled settings with experts and highly selected patients. We need to do the harder research where it's messier, but where the results are going to be more realistic and more relevant and more likely to be disseminated and implemented in the real world.
Ms. McKay, we know smoking is bad for you, yet you still see people smoke. We know being heavy is bad for your health. You still see people heavy. I think the word is awareness. Awareness, awareness, awareness. People know these things. From your viewpoint, why don't they act on them?
Well, you're right. Awareness and action are different things. I think awareness is the first step. I mean, look at the changes that have been made and people have made in their diets over maybe the past 25 years, or at least know they should make in their diets, right? So people at least have, understand whole grains, more fresh fruits and vegetables, more protein. But 25, 30 years ago, I don't think anybody was talking about that. But the real problem, obviously, is creating as Connie was saying, you need to make the right choice, the easy choice. So, I think that's the real key. In terms of raising awareness, which is, what is the first step? I think with heart failure and chronic diseases in general, it's very hard. I have found in writing about public health that the things that really grab the headlines are the acute events, the pandemics, the outbreaks, the heart attack rather than the heart failure. Somehow, stopping an acute event or avoiding an acute event or preventing yourself from, getting the flu when it's a bad flu season, people tend to listen to more than they do, a chronic disease. I think it's just, we all know this, right? It's going to come on slowly. You don't really know how to, you don't really think it's going to happen to you. So, raising more awareness certainly helps.
My parents smoked, ate steak, and drank whiskey. Most people nowadays don't do any of those things. This is a question for you, Dr. Sidney. Is there any low-hanging fruit that we can pick to reduce the size of the tsunami?
Well, it depends on what you mean by low-hanging, I think. I mean, there's things that are very clear that we have to do. Life Simple 7, for example. That's kind of low-hanging fruit, except it's very difficult to implement. I think one thing that's been alluded to here that really would go a long ways is getting hypertension treatment better, getting more people under control, because we basically know how to do it. Not that it's trivial with any individual patient, but we know the formula. There's, you can work with lifestyle, but if that doesn't work, then we have medications and we know how to use them in a way that will get 80, 90% people controlled. And that could go, I think, to me, of all the risk factors, that's maybe the easiest one to get a major national improvement in.
Last question for you, Dr. Hwang. What successful approaches by some of your members lend themselves to more widespread use?
Sure. So I think there are two major strategies I think we should all consider when we're thinking about cardiovascular health and heart failure. So number one, and a lot of our members are highly focused on this, is really thinking about healthcare disparities. So when we think about trying to raise that rate, so again, as Dr. Sidney mentioned, for hypertension control or blood pressure control being so important, to raise that, I think we have to really make a commitment to collecting the data about gender, race, ethnicity, country of origin, language of preference, education, income, social determinants. But you need that information to be able to stratify and actually see what's going on with those rates and try to improve, all of them and reduce the gaps. And the second thing there is a commitment, continued commitment from leadership to really address health equity. So one of the best examples, and I'm sure folks around the room may be aware of it, but Kaiser Permanente is pretty much an outstanding leader in hypertension control across their 12 million members, 8 regions. They routinely score 5-star, which is the highest you can get on a HEDIS measure for blood pressure control, so control rates of 80s, low 90s, right? And so the interesting thing about this and their approach on this is that if you were to look at Kaiser Permanente and think only of their African American population, they would still be 90th percentile in performance. And so right now the gap between African Americans and the sort of reference Caucasian group is about 3%, and they're continuing to try and close that. And so I think in many ways taking that disparities and health equity lens to this problem and challenge of blood pressure control, I think, is important and actually shows that you can effectively raise those rates. The second, I would say, overall, what we as a system or healthcare organizations should focus on is really trying to further that transition from fee-for-service to value-based care. So interestingly, when you think about heart failure, one entity's savings, right, reduction in heart failure, is actually another entity's income, right? Admissions for heart failure, heads in beds, et cetera. So we've got this tension in our healthcare system that we need to resolve and start to reward on better quality of care, better patient experience, and really judicious use of costs. So I think some things to look at, a lot of movement across our member health plans and moving hospital services to home. And good examples, Marshfield Clinic Security Health Plan in Wisconsin. They have a home recovery care program that includes heart failure. But in short, they've been successful in moving those groups to being cared for at home, and they have lower 30-day readmission rates by the tune of 44%, lower acute care services by 37%, patient satisfaction rates greater than 90%, and then when this is all paid for in a health plan approach in a bundled payment, and so for these 30-day episodes, the health plan has seen a reduction to 15 to 30%. So there are ways that when you can line up the finances in a way that focuses on value, that really, I think, provides a spark for the kind of innovation, both in prevention, but also in the effective management of something like heart failure. So I would give those two ideas of thought.
First of all, I apologize. I said Hwang. Your name is not Hwang. Right. McEwen, they pronounce every way you can think of my whole life. So I'm very sensitive to that. We have time for a couple of questions from the audience to anyone up here. So, yes.
Talk about the tsunami, and when we look at those rates that are rising in people under 65, and I look at what contributed to their heart failure, there are things that I think we need to think about, such as research in epigenetics, exposure, research in antibiotic resistance. These were some of the contributors that are contextual to today and what we're facing as a nation today. And if we want to prevent a future silver tsunami, right, then I do think we need to focus on that. And related to that, I would also suggest that when we talk about messaging, messaging targeted to the youth, right, but in a way that's relevant to them, because they don't care about tomorrow so much, right? It's about living in the moment. So what kind of messaging can we deliver that would improve heart health, that would resonate with youth today, in the moment? So I just wanted to contribute and add that for consideration to the panel and to the folks that are in this room.
Thank you. Anyone else? Yes.
Thank you. Great presentation. Thanks. Regarding women being the presenting with this type of heart failure where the heart is having difficulty relaxing, have you considered this large group of women, up to 20%, with a condition known as polycystic ovary syndrome, where it's a metabolic disorder that's it's wreaking havoc on the metabolic system, and we just don't know that much about how PCOS leads to hypertension. And of course, insulin resistance is the underlying factor here. But I think this is one huge opportunity for prevention that's currently being left out of the conversation a lot of the times. So have you considered something like that, this large population of women who are at high risk for heart disease that present this opportunity, this unique opportunity in potentially elucidating some of these questions that we have?
Okay, guys, you're on.
Well, I'll take a crack at that. Thank you for that comment. I think it's a really important issue, and it is one of the areas of interest in our division. We have a number of studies ongoing that include a focus on polycystic ovary syndrome. And so I think the point that you raise, it is now, I think, well known that that syndrome is associated with insulin resistance, which can then lead to diabetes. There's also a lot of hypertension associated with PCOS. So that would be a population of women at high risk for developing heart failure in general, and especially the type with preserved ejection fraction, where the heart has trouble relaxing, perhaps because of some fibrosis and other changes that occur in the heart. So that would be a population of great interest to study. Yeah, I would agree with you.
So I also appreciate the question, and thinking a little bit more about women and heart disease. And again, as I noted earlier, I think this understanding kind of women's experience tracking gender in terms of your quality measures that relate to heart disease, I think, are important. I think also for some of our members who have been very successful in raising the bar for quality in cardiovascular health across all populations, there really is this strong reliance on standardized clinical algorithms, so that when there is something, you try to, in many ways, reduce variation and potentially reduce bias. I mean, I think we're all walking around with unconscious bias. A lot of our leading health plan and systems have adopted or rolled out unconscious bias training to try and pick up that awareness where a woman's symptoms for heart disease or heart attack are more dismissed. Want to get over that concept where they can be dismissed more easily than someone like a male coming in. So I think the use of clinical algorithms, this type of approach, certainly with unconscious bias training, and also sort of interviewing and patient interaction techniques. There's something called AIDIT that many of our health plans and systems are using, which again try to enhance that patient sort of conversation engagement, so that you can get like that full history and manage potential challenges for heart failure.
Yeah, and I think PCOS is largely under-recognized in practice, it hasn't, there haven't been trials focused specifically on trying to prevent heart failure in that population. That They would be challenging to do because of the duration that one would need to follow individuals, most likely. But the efforts to be able to improve care have also, or improve outcomes, have been hampered by the lack of evidence and also, I think, the lack of diagnosis. So it's an area where research organizations and practice organizations perhaps could collaborate on trying to generate that evidence about what might work in that population.
I think you. Go ahead.
Also patient organizations, so including the patients in that conversation would be extremely helpful.
Hey, I think you had a question.
Hi, this is Sue Koob. I'm with the Preventive Cardiovascular Nurses Association. Thank you so much for the discussion today. It's been really interesting and engaging. My question is really, I guess, for the entire panel, but have you guys been looking at any research in terms of looking at utilization of nurses? Obviously, I represent a nursing organization, and we're very focused on prevention and preventing the worsening of heart failure. And we've seen a lot of success with nurse-run clinics that are really preventing readmissions of patients back into the hospital, and also helping patients once they get at home, better understand self-care and kind of focusing on behavior change. So I was just wondering, really within within the Alliance of Community Health Plans or at the NIH, when you're looking at real-world application, if there's been some focusing on utilization of the nursing workforce. Thank you.
I'm happy to take that. And so thank you for your question and comment there. So nurses do play a very large role, especially in team-based care approaches. And so as I noted earlier, in some of the pieces that are critically important for successful payer-provider partnerships is this multidisciplinary team. And one of the examples that comes up in my mind, one of our members is UPMC, based out in Pittsburgh, and they have for many years run a very successful heart failure telemonitoring program. And so what this does is identifies individuals who are recently discharged with heart failure that meet certain criteria and enroll them in a 90-day program that is, generally speaking, nurse-run. There's a hospitalist, I think, that kind of works with, again, in team-based care, but the nurses essentially at this remote monitoring control center, the patient goes home and has a tablet for two-way video conferencing, has Bluetooth, biometric, equipment on blood pressure, pulse ox scales, et cetera. And in essence, there are sort of ongoing telehealth video, video visits, but the nurses are essentially coordinating a lot of that post-discharge management and also just the sort of chronic heart failure management, and to great success. So with the UPMC program, for those members who are part of that program, the readmission rates, starting from 21% have dropped to 12%. Nationally, in that sort of Medicare population, heart failure tends to run up like 25% risk of readmission. So this is one of the programs that, frankly, couldn't be successful without this important nurse, engagement and workforce.
We're going to have to leave it here. I want to thank Betsy McKay, Connie, Hwang, Stephen Sidney, David Goff. How about a hand for our panel? Thank you very much.